Thank you, everyone. My name is Monika Kamkuemah. I'm a PhD candidate at the University of Cape Town. And the title of my oral today is Mental Health and Substance Use in Adolescents and Youth Living with HIV in a Context of Violence. So just a brief background. We know that people living with HIV, and more particularly adolescents and youth living with HIV, face an elevated risk for mental health disorders. This is both due to sometimes the effects of antiretroviral treatment, but also just general psychosocial challenges associated with living with a highly stigmatized communicable condition. So if we have a context of community violence, which is prone to trigger mental health disorders in people, this further increases their vulnerability towards mental health disorders. In looking at the context of Cape Town, which is the background and the context within which this research was conducted, it's a very volatile setting. So a lot of the settings in which the participants in this study live are peri-urban settings on the outskirts of the city, which are prone to gang violence, substance use, and a lot of absent parenting. In fact, Cape Town is one of the world's most dangerous cities in the world, surpassed only by certain cities in Latin America. 2018, the police recorded more than 2,800 murders and a homicide rate of 66 killings per 100,000, which triggered the government and the national government to send the army into these township settings in order to mediate the community violence. So the aim for this study was to investigate depressive symptomology and psychological distress, as well as substance use among adolescents and youth living with HIV between the ages of 15 to 24, living in these so-called townships in Cape Town. So some preliminary results. We had a sample of 92 adolescents and youth, of which 3 out of 4 were female. For 27% of them were neither in education, employment, or training, defined as NEET in an economic definition, and 44% were multidimensionally poor, meaning that they were deprived in more than a third of the dimensions necessary for good health and functioning and economic sustainability. 70% of the adolescents reported household food insecurity, and of which 38% experienced severe food insecurity. That is, having to cut back on meals in a day or not having enough resources to actually buy food in their household. In terms of parenting, 58% reported being orphans, having either lost one parent, and 12% of them were actually double orphans who had lost both parents. Less than half reported a biological parent as a primary caregiver. In spite of this, we did find a high level of positive parenting, or they self-reported a high level of positive parenting using the Alabama Parenting Questionnaire. And there were low scores on poor supervision, meaning that they did report that their parents would ask about their whereabouts or the kind of their friends that they hang out with, and they would enforce certain curfews. Parents being a proxy for caregiver, which would either be a biological parent or an extended family member like a grandparent. We used the internalized and enacted stigma scale devised by the HIV stigma scale group for adolescents living with HIV, and more than 2/3 had experienced some level of stigma within the past year. So our main outcome of interest, which was depression, was measured using the Center for Epidemiological Studies depression scale, of which significantly more females reported depressive symptoms compared to males, 51% and 19% of males. But looking at more generalized psychological distress using the Kessler psychological distress scale, we found no differences by gender. And we found that 44% reported experiencing some level of psychological distress within the past month. Alcohol use, and particularly harmful use of alcohol, was also quite prevalent. So 41% reported having consumed alcohol in the past month, of which more males reported frequent alcohol consumption compared to females. and 24% of our overall sample reported having binged on alcohol, meaning that they drank 5 or more drinks in succession within one sitting in the previous month. 48% of males were current smokers, consuming, using tobacco or tobaccoless products in the past month, and 25% of females, significantly less females, were current smokers compared to males. In terms of substance use, the lifetime prevalence of cannabis, illegal drugs, and other substances ranged from 27% for cannabis, 77% for methamphetamine, known as TUC, cocaine or mandrakes, so that is for hard drugs, and more prevalence of inhalants, so using glue or sniff or inhalers to get high, so 10% of that, and then 15% reported having used over-the-counter or prescription drugs for purposes other than they were prescribed for. Overall, lifetime use of any illicit substance range was 53% for males and 30% for females, so significantly higher for male youth living with HIV compared to females. Violence was highly endemic in this setting, as we expected. 84% reported moderate to high exposure to community violence. That is, they either witnessed or had heard of a killing in their community, or they had seen someone pointing or shooting a gun at someone other than the police. And so in conclusion, we found high levels of depressive symptoms and distress in these urban youth living with HIV. There was some level of parental supervision, but not adequate. So there was poor parental monitoring, despite them reporting, because their actions actually spoke to the opposite. So having a non-biological parent as a caregiver, we actually saw that they were more prone to risk-taking. Data not shown here. So how do we deal in the context of violent communities which are, where substance use is prolific and where youth are left to their own devices most of the time? So all of this can actually modify the pathway towards mental health problems in an already vulnerable population. How do we build resilience and healthy coping mechanisms? So some suggestions are via monitoring of social activities, either by parents or other community members who can step in as proxy enforcers of informal social control, and possibly providing recreational options in order to interrupt harmful pathways that predispose youth towards engaging in harmful behaviors. So in conclusion, also, I'd like to acknowledge my co-authors, Dr. Blessings Gauzi and Dr. Tolu Oni, who are very instrumental in carrying out this research. And mostly thank you to the adolescents and youth who agreed to take part in this research, sometimes sharing highly sensitive and triggering information with us. And we'd like also to thank the City of Cape Town and the Western Cape Department of Health who facilitated access to these participants. Funding was secured from the Bristol Myers Squibb Foundation Secure the Future grant, as well as the NRF and the German Academic Exchange Services. And these are my contacts if anyone is interested in further information or collaboration. And we just also like to thank the School of Public Health at the University of Cape Town and our health association in Namibia, which was a partner organization for this research. Although unfortunately we couldn't replicate the same study in a different context for comparison. Thank you.
So thank you very much. That was really interesting. I think you did very well, but unfortunately, this was almost 9 minutes.
Really?
Yes.
Wow. Okay.
So
I think I was trying to pause too much.
I really get it. And it was super interesting. So I understand why you wanted to have all the facts in there. But if you think we can do it, then I would like to do it again. And
okay, yeah, sure.
Take 7 minutes. And I'll take time again.
The pauses between, was that sufficient or?
Yeah, that was plenty.
Too long?
Yeah, no, I think it was fine. But I think you generally talked a bit slower because you were thinking about the pauses.
Yeah. And because I usually talk fast, so.
Yeah.
Okay, fine, yeah.
You can also go ahead and talk faster. That's fine.
Okay, okay.
Yeah.
No,
But I
fine,
do
I'll read
really
it.
think it was very, very interesting. Very impressive.
Okay,
Yeah.
thank you. Yeah. Okay, let me go again.
Yeah, let's do that. I'll just stop my video.
Okay, oh, sorry, just before you go.
Yeah, sure.
I'm wondering with the acknowledgements, I don't know, was that a bit too much? Because they can get kind of what?
Yeah, I don't think you need that much. I think it's yeah, it might be a bit too much.
Okay, okay.
Yeah, but it's good to show the slide for sure, and to also, like, for instance, if you want to mention your co-authors, many others do that as well, so I completely understand that. But about the funding, for instance, maybe it's fine if it's just there. Then people can read it if they want to.
Okay, yeah, that's fine. Okay, let me do this again.
So I will mute myself. You can just start whenever you're ready.
Perfect. Okay, I think I'm ready. Thank you, everyone. My name is Monika Kamkuemah, and I'm a PhD candidate in the School of Public Health and Family Medicine at the University of Cape Town. The topic of my oral today is mental health and substance use in adolescents and youth living with HIV in a context of violence. Adolescents and youth living with HIV, similar to other people living with HIV, face an elevated risk for mental health disorders. This is both due to side effects of antiretroviral treatment, as well as the psychosocial challenges associated with living with a highly stigmatized condition. So in the context of community violence, this further increases vulnerability and triggers a pathway towards mental health comorbidity. In our setting, in which the study was conducted, gang violence, substance abuse, and absent parenting are a constant challenge to communities in the Cape Town setting. So Cape Town is one of the world's most dangerous cities, of which only certain cities in Latin America surpass homicide and murder rates. In fact, in 2018, the violence rates were so bad that police and the army had to be sent in to mediate the situation. Our aim was therefore to investigate depressive symptomology, psychological distress, and substance use among youth living with HIV between the ages of 15 to 24 in these so-called townships in Cape Town. So our sample size consisted of 92 adolescents, of which 3 out of 4 were female. 27% were neither in education, employment, or training, and 44% were multidimensionally poor, according to the YMPI definition. 70% lived in food insecure households, of which 38% lived in severely food insecure households. 47%, only 47%, so less than half, reported a primary caregiver as a biological parent. In fact, 58% were orphans, of which 12% were double orphans, having lost both parents. We found high scores on the positive parenting subscale of the Alabama Parenting Questionnaire, and conversely, low scores on the poor supervision subscale. So they did report some level of parental involvement in their lives. 66% reported having faced either anticipated, enacted, or internalized stigma, according to the HIV stigma scale for adolescents living with HIV. Our main outcome of interest, which was depression, defined using the CEST-10 scale, we found that significantly more females reported depressive symptomology compared to males, and overall 44% reported psychological distress, being either mild, moderate, or severe levels, according to the Kessler Psychological Distress Scale. Overall, 41% reported using alcohol in the past month, of which more males reported frequent alcohol use, and 24% reported that they had binge drunk alcohol in the past month, meaning that they had drunk 5 or more drinks in one sitting in the previous month. Smoking, we found 48% prevalence among males and 25% among females, but which was not statistically significant. In terms of overall lifetime prevalence of any illicit substance, 27% of candidates reported having used cannabis, and 7% reported having used hard drugs, that is methamphetamine, cocaine, or Mandrex, and 10% had used inhalants to get high, and 15% had used over-the-counter or prescription drugs for purposes other than what they were prescribed for. This differed significantly by gender, with male participants being more prone to substance use. And 84% reported moderate to high levels of exposure to community violence. That is either witnessing crimes such as the police, someone other than the police pointing or shooting a gun at someone. In conclusion, we found high levels of depressive symptoms in urban youth living with HIV. We found some level of parental supervision, but poor enforced monitoring. And how do we deal with mental health problems in a context of violence where youth are often left to their own devices? Some ways in which we would propose building resilience and coping mechanisms include monitoring of social activities and providing recreational options in these low-income settings prone to high substance use and community violence. In conclusion, and to acknowledge my study participants, I'd just like to thank them for being so open in sharing their insights and experiences. And I'd also like to thank my co-authors, Dr. Blessing Skauzi and Dr. Tolly Onui, who were very instrumental in conducting this research. And I would also like to thank the adolescents and youth who agreed to take part in the research study, often sharing very sensitive and triggering information with us, as well as thanking the City of Cape Town and the Western Cape Departments of Health who made access to the facilities and participants possible. And lastly, I would like to thank my funding sources as depicted here, this Bristol Myers Squibb Foundation, the South African National Research Foundation, and the German Academic Exchange Service. And yes, here are my contacts. If anyone would like any further information or possible collaboration, yes, thank you.